So in order to evaluate a patient with a non-patient with liver disease presenting with respiratory symptoms, or to be more specific, lower respiratory symptoms, that is most commonly shortness of breath, SOB, or chest pain, or cough, or even hemoptysis, or chest wheezes. The most common, as I mentioned, is difficulty breathing is the most common respiratory symptom in patients with liver disease. And unless it's clear from the case that it might be related to this shortness of breathing might be related to pleural effusion developing in the context of liver cell failure, complicating chronic liver disease. As we all know, generalized edema is a feature of advanced chronic liver disease due to liver cell failure, and mainly to hypoalbuminemia and portal hypertension. And it starts first usually with the peritoneum, that is ascites, and then peripheral edema develops, and then generalized edema develops in the pleural space, that is pleural effusion, in the pericardium, that is pericardial effusion, and even in the limbs and the face. And there will be what we call anasarca, or generalized edema. So let's speak about if the pleura is involved, that is pleural effusion, complicating chronic liver disease with liver cell failure. This pleural effusion, of course, due to compression of the lungs, these mechanical factors will produce dyspnea. Another cause is patients who are having massive ascites, also in classic cases of advanced chronic liver disease with massive ascites due to hypoalbuminemia, as I mentioned, and portal hypertension, localizing the fluid first in the peritoneal space, and the patient gets massive ascites with generalized abdominal distension and impediment of the movement of the diaphragm. So there will be also another case, or another condition for shortness of breathing. So this might be related to pleural effusion in patients with chronic liver disease, might be related to massive ascites in patients with chronic liver disease and liver cell failure, simply. And then in the advanced cases, where we will have it shortness of breathing due to other forms of pathological involvement of the lung parenchyma, of the pulmonary vasculature, of the interstitial space of the lung, as I mentioned, due to interstitial lung disease, due to pulmonary hypertension, etc. Here will be other forms of thoracic involvement, pulmonary, to explain the pathogenesis and the presentation of dyspnea, or shortness of breathing in such cases. Usually we have to investigate in order to look for the anatomical and pathological diagnosis in such cases, and what is the anatomical and the physiological and pathological nature of pulmonary or thoracic involvement in any case with chronic liver disease, is to do, number one, a plain chest X-ray, simply plain chest X-ray, to visualize the lungs, the pleurae, the mediastinum, etc. And also to look for any lesion in the lung interstitium, or in the lung parenchyma, or in the pleural space, or in the mediastinum, any possible pathological involvement of these sites in the lower respiratory system. So plain chest X-ray is number one. We have to do also an ECG to detect any abnormalities in the heart and in the lungs, and of course we can get a lot of information about the cardiopulmonary function from looking at the ECG. So an ECG electrocardiogram, that is surface electrocardiogram, will also give some information for the condition of the heart and the lung, that is the cardiopulmonary circuit, if affected secondary to liver disease, as I mentioned before in my other presentations. So ECG is the basic, is to do a plain chest X-ray and an ECG to detect any cardiopulmonary complications of chronic liver disease, or even, as I mentioned, in acute liver disease, as exemplified by fulminant hepatic failure. This is very mandatory to do a plain chest X-ray and an ECG in patients with liver disease, whether chronic or acute. And then if the pathology is still vague or not clear or ambiguous, we have to proceed to more detailed investigations and more complicated diagnostic tests like high-resolution CT scan to detect any interstitial lung disease or parenchymal lung disease. We might need also pulmonary angio in some cases. We might need perfusion scan or ventilation scan or combined ventilation perfusion scan of the lungs. We might need contrast echocardiography, as I mentioned, contrast echocardiography to diagnose hepatopulmonary syndrome or to look for portopulmonary hypertension. We have to do cardiac catheterization in some selected cases to reach to the proper diagnosis. Cardiac cath in such cases, especially if suspecting portopulmonary hypertension. So contrast echocardiography important, cardiac catheterization important, high-resolution CT scan important, MRI of the lungs important. Also spectroscopic examination is important, and even radioisotope scans. I mentioned the perfusion scan, or especially if we are suspecting any problem in the pulmonary circulation or vasculature, to do perfusion scan, or ventilation scan also, or to combine the ventilation and perfusion scan, especially in cases suspect of having pulmonary embolism, for example. So these are all important and mandatory to diagnose the possible pulmonary pathology as a complication of liver pathology or liver disease, whether in acute or chronic cases. It's just an important reminder of what are the possible diagnostic tools which might help us in explaining and reaching to the underlying problem causing respiratory symptoms in patients with chronic liver disease, especially starting from chest X-ray, the plain straightforward chest X-ray, to the ECG, and then to more sophisticated tests including high-resolution CT scan of the lungs, or even MRI of the lungs, or perfusion and ventilation scans, or contrast echocardiography, or cardiac catheterization, or in some cases also pulmonary function tests including vitalogram, including detailed respiratory functions to detect any diffusion abnormality or any obstructive abnormality of the lung, or any perfusion abnormality, because we all know that the abnormalities in the function might be either an obstruction defect or a diffusion defect if related to the vasculature, or if related to the interstitium, or perfusion defect if related to the pulmonary vasculature. So we have to do the test to detect any of these functional defects: perfusion, diffusion, or ventilation pulmonary disorders or pulmonary defects. Thank you so much, and I will see you in my further clinical topics, mini talks and presentations. Have a nice day. Professor Tarek Ali.